So thanks everyone for coming this morning to the first session. So I'll start us off by talking about sternoclavicular joint injuries. So I'll just briefly talk about some background and some relevant anatomy, and then focus the talk on treatment for acute dislocations. Sternoclavicular injuries are uncommon injuries. Most commonly, it's due to a high energy mechanism. For example, a motor vehicle accident. It can also happen in high-impact sports. Typically, it's classified as either an anterior posterior dislocation of the joint. And it's important to remember, because the medial clavicle physis has delayed closure, that this can also be a physeal injury in patients less than 25 years. And mechanism is typically a lot of compression force in the shoulder when it's either in protraction, causing a posterior dislocation of the joint, or with the shoulder in retraction, causing an anterior dislocation. So I'll just briefly go over some relevant anatomy. Of course, the joint is close to many important structures, so 75% of patients will have a mediastinal structure within 1 centimeter of the joint. And most commonly, this is the brachiocephalic vein. Occasionally, it can also be the artery as well. In addition, the trachea, esophagus, and lung are also in close proximity and can be injured in posterior dislocations. Secondly, in terms of the actual joint, it's a saddle-shaped synovial joint. The joint is incongruous, and there's an intra-articular disc. And the medial clavicle articular cartilage only covers the two-thirds of the end, and it's usually located along the anterior-inferior aspect, as you can see there. Stability is provided by the capsuloligamentus complex. So this involves a number of ligaments, including the anterior and posterior sternoclavicular ligament, the costoclavicular ligament, and the interclavicular ligament. Of these, the posterior sternoclavicular and costoclavicular ligaments are reported to be the strongest. So you can see here, this is a cadaveric specimen. You can see the anterior sternoclavicular ligament, costoclavicular ligament, and then the interclavicular ligament there. In terms of some relevant musculature, the subclavius muscle runs along the clavicle, and so this separates the mediastinal and great vessels from the clavicle. So staying anterior, this can be a landmark and be protective of injuring anything. And then similarly, along the sternal side, the sternothyroid muscle and sternohyoid muscle help protect from the mediastinal structures. And then finally, it's just important to remember that this joint, the movement does occur through this joint. So the clavicle will move anterior posteriorly, superiorly inferiorly, and there's also a rotation component. And so any injury to this joint may affect scapulothoracic motion, AC joint, and ultimately shoulder function. So now moving on to management for acute dislocation. So start off with this case, so a 30-year-old female who was involved in an MVC. You can see here that she has a posterior dislocation of the right SC joint. And so typically this requires urgent attention. In terms of the assessment, it's important to assess for things like dyspnea, choking, hoarseness, neurological symptoms, and weak pulses, so any associated injury from the posterior dislocation. And it's also important to have a vascular workup. So in treating this, it's usually good to have cardiothoracic or vascular backup, and then when you're draping this out, to have all appropriate sort of access and exposure. And this would also involve having the right instruments for the thoracic backup as well. If this is seen acutely, a closed reduction can be attempted, and so typically the patient would be positioned supine. You put a bolster under the shoulder in order to provide some shoulder retraction. And then you can pull traction along the arm and sort of try to cantilever that posterior dislocation anteriorly. Occasionally, you can also carefully try to put a percutaneous clamp along the medial clavicle to try to grasp it and lift it anteriorly. And the success rate has been reported to be about 38% for this closed reduction. Usually works if it's more acute, less than 48 hours. If it's irreducible, then open reduction may be needed. So the approach is fairly straightforward: incision over the joint, going through the capsuloligamentus structures, and exposing the medial clavicle and sternum. And then similarly, putting a clamp along the medial clavicle, pulling some traction on the arm, and then lifting it anteriorly. And then afterwards, you can test the stability. in terms of different stabilization procedures, there's a number that have been described and that are possible. So commonly, transosseous fixation with suture, for example, may be performed. So typically, some drill holes are made along the medial clavicle and manubrium. So this can be made either unicortical and passing the suture through the joint, or bicortical. If you go bicortical, you want to make sure you really put something underneath to protect, plunging into the mediastinum. And then typically this can be secured in a figure-of-8 fashion. And different types of sutures can be used, including fiber wires or Merceline tape. Suture anchors may also be used. So this is just an example in a cadaver, and then in a actual surgery. Similarly, instead of suture, allograft and autograft can also be used if the joint is unstable, if there's a substantial ligament disruption, and this can be done in similar fashion for figure-of-8 method. And so just some other pictures here. And this type of procedure, has been described and reported for some time now. This is one of the classic biomechanical studies from the early 2000s, testing the semitendinosus tendon figure-of-8 construct, which is shown to have good biomechanical properties for both anterior and posterior translation. And of course, the joint can be plated as well, but as we discussed earlier, there is motion through this joint, and so there is a possibility of plate loosening. And so if the joint is plated, there should be consideration of possibly removing the plate in a delayed fashion. In terms of outcomes, a lot of the studies are retrospective case series. This is a pretty uncommon injury. And so this was a review of 24 case series. So they looked at functional outcome scores. And you can see here for posterior dislocation, the outcomes are fairly good, both for closed reduction and open reduction, so 100% and around 90%. Functional outcome. And if these are treated, typically they do better if they're treated acutely as opposed to for sort of a chronic reconstruction. But it is important to note that there are complication rates for surgical treatment of this, and this includes things like recurrent instability, developing post-traumatic arthritis, the need for implant removal if the plate is placed. And then interestingly, in this review, they didn't have any reported cases of neovascular mediastinal injury. So going back to this case with the posterior SC dislocation, this is thanks to Dr. Canamere, one of his cases. So this patient underwent an open reduction and then had a semitendinosus allograft reconstruction and backed up with suture tape augmentation, and also sort of secured with a mini fragment plate. This is a O-arm spin confirming the reduction. And then postoperatively, he was initially braced, non-weight bearing, and then he had a gradual increase of his range of motion and weight bearing. And at 7 months, he was doing well with minimal pain and no functional restrictions. So now moving on to anterior dislocation. So this is a 20-year-old male who's involved in MVC. You can see that here that he has a left anterior sternoclavicular joint dislocation. So these are typically treated conservatively. A closed reduction attempt can be considered if it's acute, but it's often difficult to maintain the reduction. So it's similar to a posterior dislocation, except the force is applied sort of posteriorly to reduce that anterior dislocation. And then if the patient becomes symptomatic due to things like prominence or persistent instability, then surgical intervention can be considered. This has been looked at for some time. This is more of a classical study here. So they treated these patients, these anterior sternoclavicular dislocations, conservatively. So they had 13 patients, 10 with follow-up data, and they looked at functional outcome scores, and they found that 7 out of the 10 had good outcomes. And then if you look at the patients here, the ones with poor outcomes, or the lowest functional scores, these patients had sort of associated shoulder injuries, including shoulder dislocation and arterial injury as well. And then just going back to that other case series, you can see here these anterior dislocation functional scores. Not as good as the posterior dislocations, but reasonable. So about 70% and excellent and good functional outcome scores for non-operatively treated, and 85% for closed reduction. But these do also have complication rates. So this includes persistent pain, decreased functionality, developing post-traumatic arthritis, cosmetic deformities, and some patients report inability to return to sports. And so for young, healthy, and active individuals with anterior sternoclavicular joint dislocations, consideration should be made to treat these with either closed reduction or open reduction. So in summary, first thing is to make sure these injuries aren't missed. So usually, having a CT scan to assess for dislocation, looking at the mediastinal structures, and then if they're less than 25 years old, to make sure they don't have a physeal injury. For anterior dislocations, usually treated conservatively. Closed reduction can be considered if it's acute, and then surgical intervention is usually considered if the patient becomes symptomatic, or acute stabilization could be considered in sort of a young, athletic and active individual. Posterior dislocations usually treated with either closed or open reduction. Usually, should be done in the operating room with a vascular or cardiothoracic sort of backup. And then there are many different stabilization techniques, transosseous suture or allograft or autograft reconstruction. If there's articular degeneration, this is more for chronic treatment. A articular resection can be considered as well. And then, using a plate, screw, or hook plate can also be used, but consideration should be made for implant removal. Okay, thank you.